he came to us in Pittsburgh after working at the hospital for sick children in Toronto, Canada, and has established himself as a well-published and tireless advocate for the epilepsy community. Along with his wife and 3 girls, he's become a fixture and an honorary Pittsburgher, and he's an ardent supporter of the community and Epilepsy Association at large. So thank you, and I'll turn it over to Dr. Abel.
Thank you very much for that wonderful introduction, Kevin. And I'm really excited, and I'm glad that you called me a Pittsburgher. That made me very happy. We've been here for about 2.5 years now. It's really a wonderful city. And, you know, I think it's okay for me to say this since I'm with an epilepsy advocacy group right now. But the reason I decided to become an epilepsy surgeon is when I was a child, I actually had benign Rolandic epilepsy. And I was very fortunate to have, you know, grown out of benign Rolandic epilepsy, which children with benign Rolandic epilepsy do. But so epilepsy really means a lot to me, and it's not just, it's more than just a job for me. And so I just want to encourage you, you know, if any questions come up, or if there's anything I can help you with, feel free to email me or contact me somehow. Today I'm going to talk about epilepsy surgery in pediatrics, and because that's what I do. And I'm going to try to talk for about 30 minutes and leave as much time as possible for Gretchen. We'll have some time for, are questions okay?
Oh yeah, absolutely.
Okay, awesome. So I'm going to try to leave as much time as possible for questions so that we can really focus on what you're all most interested in, or what kind of questions you have. So what is epilepsy? That's always how we start this talk, but most people in this group know what epilepsy is. It's the most common of severe neurologic conditions, and it's characterized by spontaneous and recurrent seizures, or even just having one seizure, but being at risk for having other seizures. And it's an enormous public health problem. It affects 1 in 26 people over their lifetime. There are about 17,000 children in Pennsylvania that have epilepsy. We evaluate hundreds of new children who have new diagnoses of epilepsy every year. Children who do have epilepsy, about 30 to 40% of them have what's called drug-resistant epilepsy. And so that means they've tried 2 medications at a time, and they're continuing to have seizures. And the reason we call that drug-resistant epilepsy is because what the literature would say is that after you've tried 2 medications, the odds of responding to a 3rd medication, meaning getting your seizures controlled, is 5% or less. The other thing that's really tough for us to talk about is SUDEP, or sudden unexpected death in epilepsy. And though this is really under-recognized, SUDEP is the 2nd greatest cause of years of life lost by any neurologic condition, second only to stroke. And the reason for that is because SUDEP often affects people with epilepsy early in their life. And SUDEP is much more common in people who have drug-resistant epilepsy than controlled epilepsy. And epilepsy contributes to major changes in quality of life, education, and neurodevelopment. Why epilepsy surgery? Epilepsy surgery has a really big stigma attached to it, and for good reason. Going through brain surgery of any kind, or any kind of procedure of any kind to try to treat seizures can be a really difficult and stressful thing to go through. But the reason why we consider epilepsy surgery, and the reason why I do epilepsy surgery, is because there's really good evidence for it being more effective than taking care of patients with drug-resistant epilepsy than medications. And so these are two studies of epilepsy surgery for temporal lobe epilepsy surgery, which show the superiority of removing the temporal lobe compared to doing continued medical management in patients with temporal lobe epilepsy. Those two studies were done in adults, but we actually have some relatively new data, and this is data from India showing that if you randomize patients to either an epilepsy surgery now or epilepsy surgery later group, the patients who have epilepsy surgery have better outcomes than the patients who do not have epilepsy surgery. And the way that they were able to ethically do this study in India is that in India, they have such a huge population and such a long waiting list for epilepsy surgery that they were able to ethically randomize patients to these two groups. And so the upshot is that if you've been on 2 or more medications and are still having seizures, you should be referred to an epilepsy center that can consider epilepsy surgery. So when should epilepsy surgery be performed, and why is there urgency? And the reason there's some urgency in performing epilepsy surgery is that anti-seizure medications can independently influence neurodevelopment. And so these medications can, if taken long enough at certain doses, can have an effect on your IQ. Seizures can also independently influence neurodevelopment. And so having seizures can also influence your development and your IQ. And then interictal discharges, meaning the brain activity that's associated with seizures but occurs between seizures, can also influence neurodevelopment. And it has been shown to be an independent predictor of having a decreased IQ. The second line of reasoning for early epilepsy surgery is the earlier epilepsy surgery is performed, the higher the rate of long-term seizure freedom. And so in babies, people have shown that if you do hemispherotomy within the first 3 years of an epilepsy diagnosis, so this is in young children, it's associated with a higher rate of seizure freedom than patients who waited till after 3 years. And there's also a recent meta-analysis, meaning a combination of many different studies, showing that if you have epilepsy surgery within the first 10 years of your diagnosis, that's associated with better seizure freedom rates long-term. And the rationale for that is that in a way that we don't yet completely understand, epilepsy is probably something that can spread in certain conditions, meaning the more seizures you have, you can recruit these other brain areas into the epilepsy. And so that's something that there's some evidence for, but we really don't completely understand yet. And then finally, epilepsy surgery has been associated with higher quality of life in the long term compared to medical management. The other important thing to note, and this is just a slide from a paper, is that the best predictor of cognitive development after epilepsy surgery is whether or not you become seizure free. And so,
cancel.
What's
Cancel.
That? No. And this is just a slide that shows that. And so, by the way, if there are questions at any point, I think it's okay to interrupt me and ask a question. But this slide goes over what kinds of epilepsy surgery are there. And when I'm talking to patients, I generally explain that there are 2 main types of epilepsy surgery. There's one type of epilepsy surgery where our goal is to cure epilepsy or to dramatically reduce the the number of seizures with the goal of curing epilepsy. And so we try to do this type of a surgery when someone has focal epilepsy. So that can be epilepsy from a focal cortical dysplasia, or an abnormality in the brain, like a tangle of blood vessels called a cavernoma, or a tumor, or a focal cortical dysplasia. And so in general, if we have focal epilepsy and we can see an abnormality on an MRI, we will offer surgery sometimes and oftentimes in patients that are not even drug resistant. And so the types of surgeries that we offer for patients who have focal epilepsy like this are, sometimes we'll do a procedure where we place electrodes in the brain to really figure out exactly where the seizures are coming from. But then that surgery will often lead to a resection surgery, which is like the traditional type of epilepsy surgery where we do a craniotomy and we remove the part of the brain causing the seizures. Sometimes we're able to do something called a laser ablation, where we place a laser fiber into the part of the brain causing the seizures and ablate the part of the brain causing seizures without doing a craniotomy. For children who have hemispheric epilepsy, meaning they have severe damage to one hemisphere and it's causing epilepsy, we'll sometimes disconnect that entire hemisphere, and that's called a hemispherotomy. And there are other times where there's a lobe of the brain that's causing seizures, and we'll do something called a lobectomy. The other major category of epilepsy surgery is palliative epilepsy surgery, and that's where seizures aren't coming from a single part of the brain, but we're performing a procedure with the goal of trying to slow seizures down, improve quality of life, or reduce injuries from seizures. And so one example that I forgot to list is something called a corpus callosotomy. And so for children who have seizures, atonic seizures, which are also called drop attacks, they often fall frequently from their seizures, and they can get head injuries that lead to having to go to the emergency room often. And we can sometimes do a procedure, we offer a procedure where we can disconnect one of the pathways in the brain that's important for seizures spreading quickly. It's called a corpus callosotomy. And we can do that either with a laser fiber without a craniotomy or through a craniotomy. And that's frequently associated with either the drop attacks going away or reducing dramatically in their frequency. Other palliative epilepsy surgery options are vagus nerve stimulation, responsive neurostimulation, and also deep brain stimulation. And I'll go over those a little bit more later on. But these are approaches where we place a stimulator either in the brain or in the neck, where we're trying to change the brain's activity to reduce seizures. This is in general, this is a little bit of a complicated slide, but in general, this is kind of how we think about what type of epilepsy surgery to offer someone with epilepsy. And so for someone with focal epilepsy, if their MRI is negative, meaning they don't have a structural abnormality on their MRI, if they're drug resistant, we can offer like a resective surgery, usually after a period of invasive monitoring, which is where we place electrodes in the brain. If they're drug responsive, we generally just keep medications going because they're working. In someone with an abnormality on their MRI, like a tumor or a cavernoma or a focal cortical dysplasia, we'll often offer surgery up front because we have an abnormality in the brain that we can go after, and that has a better odds of leading to seizure freedom, even if you're drug responsive in the long term. For patients with generalized or multifocal epilepsy, meaning seizures are coming from multiple areas in the brain, in patients who are drug resistant, we offer vagus nerve stimulation or deep brain stimulation, or if someone has atonic seizures associated with injuries, we offer a corpus callosotomy. There have been some trends in epilepsy surgery recently. One of the trends is moving away from doing traditional types of epilepsy surgery to moving towards less invasive techniques, like for example, something called stereo EEG, where rather than doing a large craniotomy to place electrodes on the brain, we place these really small millimeter-sized electrodes through the skin deep into the brain. That's something that is not only less invasive, but has also been shown to be more safe in some of our published work. And another trend is using laser ablation rather than resection to try to avoid a craniotomy. And so, for example, we've been using laser ablation to perform corpus callosotomy in patients who have atonic seizures, and that's a way of avoiding a craniotomy but achieving the same benefit. And another major trend is neuromodulation for epilepsy. So there have been a lot of advances in the types of neurostimulators that we have for epilepsy. And so one example is closed loop vagus nerve stimulation, where the vagus nerve stimulator stimulates automatically in response to changes in heart rate, which can be related to seizures. And also DBS and RNS are two new technologies for epilepsy surgery. I'm just going to show a couple examples of curative epilepsy surgery. The most important thing we do when we're trying to cure someone's epilepsy is find where the seizures are coming from. And there are different ways that we can do this. If someone has a brain tumor or a clear structural abnormality on their MRI, then oftentimes we can do epilepsy surgery without any additional testing. When the MRI is not as helpful, sometimes we have to place electrodes in the brain, and we try to record the brain directly when someone's having a seizure, so we can see exactly where the seizures are coming from. Identifying exactly where the seizures are relative to where important brain functions are, like language or motor functions, is really important, because when we're trying to treat focal epilepsy, we want to take out the seizures, but we want to leave all the important things like motor function and language function intact. And so these are different methods for placing electrodes in the brain. In the top here, you can see the traditional method which has been done in the United States since about the 1980s or 90s, where a craniotomy is performed and electrodes are placed directly on the brain. What we do more commonly now is place electrodes like this, where rather than doing a craniotomy, we place electrodes kind of through the skin and kind of deep into the brain, called stereo EEG. These electrodes are sometimes important for finding the focus, but the most important thing is if we have an MRI that shows us an abnormality, like the one you can see here. This is an abnormality that happened to be really close to language function, and so we had to place electrodes in the brain to figure out exactly where language was relative to this abnormality. So again, this is that same picture. This is a focal cortical dysplasia, and this is a patient where we placed electrodes on the brain to figure out exactly where the seizures were coming from. And we were able to figure out that the seizures were indeed coming from that abnormality. But the other important aspect of placing these electrodes is that we were able to figure out exactly where language was relative to where the seizures were coming from. And we were able to do a surgery that protected language function, but removed the abnormality that was causing the seizures. And this is a patient that fortunately is now seizure-free, about 2 years out from surgery. And that's a patient that had a traditional type of brain surgery where we do a craniotomy to remove the seizure focus. This is a patient who had a different type of technique called stereo EEG guided laser ablation. And so you can see here that this is a patient who had seizures coming from the occipital lobe. And so we have these electrodes that are implanted in the occipital lobe. And we found that the seizures arose from a very small area in the brain. And so we removed the electrodes after we identified the seizures. And then without performing a craniotomy, we placed this laser ablation probe into the area that was causing the seizures. And then in the intraoperative MRI scanner, we then performed a laser ablation while the MRI showed us exactly which area we were ablating. And so this is a way of doing a very controlled treatment for focal epilepsy. The literature shows that this is not quite as effective as doing a traditional type of brain surgery, but it is associated with, it doesn't require that a craniotomy is done. And so it's associated with about a 30% rate of seizure freedom compared to a 50% rate if we were to do the traditional approach. But this allows us to do a less invasive procedure for epilepsy. And this is another picture of that same patient showing the laser ablation of the area that was causing seizures. This is another example of MRI negative epilepsy that was treated with laser ablation. This is a patient who had a stroke shortly after birth that caused their seizures. You can see this injury to the brain that was caused by the stroke that occurred after the child was born. This child's now a teenager with drug-resistant epilepsy. And we placed these electrodes into the brain to figure out exactly where the seizures were coming from. We found that the seizures were actually arising from an area deep in the brain called the insula. And so we performed an insular laser ablation. And you can see here the area that was ablated without doing a craniotomy. And this patient's now seizure-free about 1.5 years after surgery. So they had a very good outcome. There are other patients who need larger epilepsy surgeries. And one of the more common procedures we perform in children is something called a hemispherotomy. And this is a procedure where seizures are affecting one hemisphere of the brain, but not the other hemisphere. And so when seizures are quite severe, we'll actually do a procedure where we disconnect the bad hemisphere from the good hemisphere so that the patient can go on and have his best seizure freedom as possible. Doing this type of a big surgery has a lot of implications on quality of life because doing this procedure can be associated with developing weakness on one side and losing peripheral vision on one side. And so this procedure is reserved for patients who either already have really severe damage to one hemisphere of the brain or have really, really severe epilepsy. This slide shows the different ways of performing a hemispherotomy. The original way was just to do a procedure where half of the hemisphere was just removed. Now we are more likely to do a procedure where we just disconnect the hemisphere because we now know that that's associated with lower rates of complications than these other traditional techniques. I wanted to also provide some examples of palliative epilepsy surgery. This is a patient who had atonic seizures, and she was referred, she had about 30 seizures a day and up to 15 drop seizures per day. She was on 4 medications, and she was referred to our clinic for vagus nerve stimulation. However, given the frequency of her atonic seizures, we also discussed performing a laser ablation callosotomy. And so you can see here, I show these pictures because you can see the corpus callosum here. And we placed the laser ablation probe this way. We placed 3 different probes into the corpus callosum so that we can disconnect the corpus callosum to try to stop the drop seizures. And this is what it looks like after it's done. And so you can see that those fibers, the corpus callosum, are are ablated by the laser ablation. I have a little video here that shows it. So you can see the ablation here. And this particular patient has not had a drop seizure since their calcisotomy. And so this can be a highly effective treatment for atonic or drop attack seizures, and can now be performed without a craniotomy. There's some patients who still need a traditional calcisotomy if their corpus callosum is too thin to allow for the laser ablation to be performed safely. But this is something that's an option now for patients who have drop seizures. Vagus nerve stimulation is one of the most common forms of palliative epilepsy surgery that we perform. Is there a question? I'll keep going. But definitely let me know if there are any questions. Vagus nerve stimulation is one of the most common forms of palliative epilepsy surgery. It can be used in almost any type of epilepsy. About more than 50% of patients will have a 50% or greater reduction in seizure in seizures. This is a typo on the screen. It didn't mean greater reduction in seizure freedom. About 50% of patients will have a 50% reduction in seizures. No one really knows definitively how vagus nerve stimulation actually works, but it's thought to work through these vagothalamic afferent fibers, which is just a fancy term for these connections between the vagus nerve and the thalamus. And the brain, or the thalamus is like the brain's grand central station. So the idea is that if you change the activity in the thalamus, that you can change activity in the brain more globally. But there are other views that stimulating the vagus nerve actually changes the body's immune response. And so people are also now, some groups are also now using vagus nerve stimulation to treat other things like depression or rheumatoid arthritis. And so we know that in certain patients, vagus nerve stimulation is highly effective. We don't know exactly how to choose those patients, but because it is a relatively safe treatment, we perform it quite often in children with severe epilepsy. So I actually went over this top part already. The surgery itself is generally safe, well tolerated, and yields few side effects. The challenge is that there really is not great data in children younger than 12. And there's limited randomized controlled trial data in children younger than 18. And so we probably need more and better studies to really understand the outcomes of vagus nerve stimulation. But in about up to 60% of patients, it can be effective in reducing seizures up to 50%. And so this is just a plot that shows that greater than 50% of patients have greater than 50% seizure reduction, and up to 20% of patients will have a 90% rate of seizure reduction. And the caveat to that is 20 to 30% of patients don't have any response. And so that's kind of one of the downsides of vagus nerve stimulation. And this is just a plot that shows the various outcome studies of vagus nerve stimulation in the pediatric population. And you can just see that the seizure reduction rates are highly variable across these different studies. And it just illustrates that we really need some well-done studies to be performed, even though vagus nerve stimulation has been around such a long time. one of the potential upshots of VNS, which is really important to consider, is that recent data shows that in long-term surveillance of sudden unexpected death in epilepsy, patients with vagus nerve stimulator therapy appear to have lower rates of SUDEP than patients who are not treated with vagus nerve stimulators. And so that's another thing I'll go over with patients who are considering vagus nerve stimulator therapy. DBS and RNS are two relatively new technologies for epilepsy. DBS stands for deep brain stimulation, and it often refers to when we place electrodes into the thalamus directly. And so with VNS, we're performing a procedure that we think influences the activity of the thalamus, but with DBS, we're placing electrodes into the thalamus directly. Responsive neurostimulation is when we place electrodes either into the thalamus or into the seizure focus. For example, if the seizure focus is in a part of the brain we can't remove, like motor cortex, and then we record from the brain when seizures are occurring, and then we set the RNS device so it detects when seizures are occurring and stimulates only in response to those seizures. And so that's why it's called responsive. The first use of DBS to treat epilepsy was probably in the 1950s. The initial target in published studies is 1973. And there are benefits that include seizure reduction reported in even early studies. And DBS and RNS have both shown a lot of promise, though data is more limited because these are newer technologies. And so one question I get asked a lot is, when do you perform DBS or RNS, and why not vagus nerve stimulation up front? And actually, oftentimes we'll offer vagus nerve stimulation first, unless we have a very good reason for DBS or RNS. There are some patients that just would prefer not to have VNS, and they may decide to have DBS or RNS that's used in a way similar to VNS. Or for patients with focal epilepsy that's in a part of the brain we can't remove, RNS is probably more effective than VNS. And this is an approach where we know where the seizures are coming from, but it's a part of the brain we can't remove. We place an RNS electrode into the area where the seizures are coming from and stimulate that part of the brain directly when seizures occur. This is what an RNS device looks like. There's a battery pack that's implanted in the skull that's then connected to two electrodes. The electrodes then detect when seizures are occurring, and when the seizures are detected, the brain causing the seizures is stimulated to stop the seizure. And so this is a fairly recent clinical trial of RNS efficacy. And so you can see that this is the difference. The blue is the group where the stimulator is turned on. White is where the stimulation is not turned on. And you can see their seizure rates are much higher in the group where the stimulator is not turned on. But then when the stimulator is turned on, the seizures go way down. And so this is some of the evidence for the efficacy of RNS. And so the question is, when should epilepsy surgery be considered? And there are a couple different reasons, and this is just what I'll go over in conclusion. I want to leave as much time as possible for questions, but epilepsy surgery should be considered when 2 or more medications have failed, or we're in a phase of drug resistance. If there's an abnormality on the MRI of the brain, epilepsy surgery should also be considered, even before drug resistant. If there are severe medication side effects or seizures are dangerous, if seizures are associated with progressive neurologic deficit, epilepsy surgery should also be considered. With that, I'll take any questions.
Thank you so much, Dr. Abel, for that wonderful presentation. We do have a few questions for you. I had a question emailed to me earlier today. When should an infant diagnosed with infantile spasms be evaluated for possible surgery?
So I think it depends on I think a full evaluation, in a child with infantile spasms, a full evaluation should be done that includes an MRI and potentially a PET examination to look for a focus of the seizures. Generally, infantile spasms, we try to control first with vigabatrin. If the vigabatrin doesn't work, we then try ACTH. And if that doesn't work and there is a focus, though there's certainly not always a focus in children with infantile spasms, then we would try to offer surgery as early as possible. And the reason for that is that infantile spasms can be associated with epileptic encephalopathy. And there's this idea that the seizures associated with infantile spasms and the abnormal brain activity associated with infantile spasms should lead us to surgery sooner rather than later. And so in children with infantile spasms who did have hemispheric epilepsy or lobar epilepsy, I've done surgery as early as 2 months for a child with frontal lobe epilepsy, and I've done surgery as early as 3 months of age in a child with hemispheric epilepsy. And so if we can find where the seizures are coming from, and they really are coming from one place, we try to do surgery as early as we can. And doing an early evaluation is the most important part of that.
Okay, all right, thank you very much. Okay, and I do have another question. How does the efficacy of surgery and surgical devices like VNS compare to long-term use of medications? Is it more likely that a patient will achieve a higher rate of seizure reduction doing surgery than just taking medications?
That's a really good question. And the randomized controlled trials of, say, vagus nerve stimulation and DBS and RNS would suggest that in patients with drug-resistant epilepsy, meaning they've been on 2 medications, those studies would suggest that having one of these devices implanted in the appropriately selected patient would be superior to medical management. And so, so you wouldn't want to have one of these devices if you were still trialing 2 medications. But if you've been on 2 medications and you're still having seizures, even a couple seizures a year, then it would be worthwhile to consider one of these devices. I would say important to consider one of these devices.
Okay, all right, thank you. Okay, now those are the questions in the chat box. Does anyone else have any questions for Dr. Abel? You can feel free to unmute yourselves and to ask him. So please feel free to do that now if you would like to. Okay. All right. Well, I think you pretty much covered everything. Really, you did a great job, and we really appreciate you being here.
I have one question. Sorry, I have a question.
Yes, no problem.
So my mom was actually the one that posed the question about infantile spasms. She was diagnosed at the end of December. She initially was diagnosed at 6 weeks with focal epilepsy. She failed Keppra and Trileptal. And then she was put on Zonegran. She was seizure-free for about 3-4 months. She had a normal EEG in October and then started having the spasms in December. She's already failed vigabatrin. She actually showed toxicity to vigabatrin. We noticed like the water drops in her motor centers in her brain on the MRI. And we believe she's also failing ACTH. We haven't really seen a difference. We're scheduled for our 24-hour video EEG tomorrow. That'll be 2 weeks on the ACTH. Our neurologist right now, we've pushed and pushed and pushed and pushed for a PET and those other things. And she is saying no, that we wait.
I think I would do. Is there an MRI?
We do. And they did not see anything. They didn't see focal cortical dysplasia or anything like that. But yeah, we've kind of pushed and pushed and pushed for this PET, and she has basically said we need to wait.
If you want, I know it's kind of tough talking about one of your loved ones. In a forum like this, if you want, I'd be happy to talk with you.
Yeah.
Later on.
That would be that would be wonderful.
Say you were considering going across.
Yeah, because we were considering actually like flying to UCLA to meet with. I don't know if you're familiar with Dr. Hassan at UCLA. He was willing to do the PET and do the surgical workup. And our doctor has kind of flat out denied it. So.
Yeah, why don't you send me an email?
Okay. Is your email on the?
I'll just
let me write it down.
I'll just put it right here.
Okay, perfect.
That.
Okay, wonderful.
We can also connect you to Dr. Abel if you'd like.
Yeah, that would be wonderful.
Oh, I see he has.
Yeah, okay, we will copy that and we will send you an email.
Okay, yeah.
Okay, wonderful. Thank you so much. I greatly appreciate it.
No problem.
Okay, great. Are there any other questions?
Yes, I have one.
Okay.
Can you hear me?
Yes.
Yes.
Okay. First of all, I think that it was excellent, everything that you said. But do you know Dr. Motamedi, Ghulam Motamedi from Georgetown?
I don't know. I don't think so.
You don't think so? Oh, he's my epileptologist, and he just reminds me so much of you. But you've just
I'll take that as a compliment.
No, but I think that you're my my grandniece's doctor, Baby Wyland.
I couldn't say either way.
Yeah, but you're just wonderful. So thank you very much. It was an excellent presentation and very, very informative. So thank you very much.
Thanks for your comments.
Okay, great. And there was another question, and I'm just going to read out loud for everyone that it looks like Dr. Abel may have answered, but it is, can a PET scan show a lesion not visible in MRI? And he did say yes. So I don't know if you want to go.
Yeah, I can give a little bit more explanation. So whenever we're trying to find a seizure focus, we want to use the most sensitive methods we can for identifying where the seizures are. And if we do an appropriate MRI and we can't see an abnormality in the brain, but we still suspect that there is an abnormality, the next step is to do what's called an FDG PET. And that's a PET study where we're looking at metabolism in the brain. And sometimes we find these focal areas of reduced metabolism that indicate a seizure focus. And so PETs can be very helpful. The other thing that can be helpful is a MEG. And so that stands for magnetoelectroencephalography. But that's a study where it's like an MRI, but it actually looks at electrical activity in the brain. And that study can, in certain cases, be helpful. But the bottom line is that we try to do everything we can to, as sensitively as possible, identify where the seizures are coming from.
Okay, great. We also have another question. Do they ever find the cause of a seizure?
We often are able to find out what's causing the seizures. But But the thing that's really important to note is that epilepsy is often a symptom of another condition. And so in some patients with epilepsy, that condition is really obvious. So in someone with a brain tumor who has seizures, the seizures are often related to the brain tumor. Or in someone with a cavernoma and seizures, the seizures are often related to the cavernoma. And if we do a procedure to remove one of those things, the seizures get better. But there are also many patients who have epilepsy where we can't find a cause. And so for patients with MRIs that are negative, where they have focal epilepsy, when we do surgery on those patients, we often find that even though their MRI was negative, meaning they had a normal MRI, that if we take the part of the brain out that was causing the seizures, that we find a focal cortical dysplasia. And so even when you have a normal MRI, it doesn't mean that your brain is completely normal. And then in other situations, we'll find a genetic abnormality that causes seizures, but our understanding of the genetics of epilepsy is still very new. And so we're not always able to find the cause of seizures. So we often are able to figure out what the cause of seizures are, but not always. And that can make things kind of tricky.
So I just would like to once again thank you, Dr. Abel, and our sponsors for this series: LivaNova, Greenwich Biosciences, Zogenix, I apologize, Neurelis, Aquestive Therapeutics, and UCB. Thank you all so much for taking time out of your evening to participate, and I hope that you all stay safe and healthy.